So now we'll talk a little bit about novel modes of ventilation, and we'll talk through the hype and the reality of the benefit of each mode. Again, I'm Carolyn Levita. I'm the Director of Respiratory Care at MGH. These are my disclosures, the same ones as just a couple minutes ago, but I don't think any of them impact what we're going to discuss today. We'll talk through some novel modes of ventilation. Some of these are proprietary to specific ventilators, which is something that we need to be cautious with. And we'll talk about the negative and positive aspects of use for each of these. I do want us to set up a timeline of some innovations in adult mechanical ventilation. And you can see somewhere in the late 80s to the 90s, there was this explosion of various modes of ventilation. In the past, what was typically used was either controlled mechanical ventilation or SIMV in the 70s, which was more of what was really billed as like a weaning mode where you could, quickly decrease the set respiratory rate, allow the patient to assume more of the work of breathing. But then all of these other modes came out, 10 to 20 years later. First, I'll start talking about airway pressure release ventilation, or APRV. This is commonly known to support patients with severe hypoxemic respiratory failure. This is how it actually works. I think if you don't use this commonly, you may have heard about APRV, but don't necessarily understand the specific mechanism. So what is set on the ventilator are a high pressure, which is here, as well as a low pressure. The high pressure maintains recruitment every so often, which is determined by the frequency. There is a release from this high pressure to low pressure. That release is actually responsible for CO2 clearance. There's a large exhalation that you can imagine that happens when you go from a high pressure to a low pressure, so CO2 is cleared that way. The high pressure maintains recruitment, and you can see that the release period, the time, the T low, is very, very short. So you don't have much de-recruitment when you go from a period of high pressure to low pressure. Spontaneously breathing can occur at any point during the cycle of APRV. This is one of the benefits of APRV, is that spontaneous breathing is maintained, and so it's been shown that lower levels of sedation may be needed. Setting these high and low pressures are really based on inflection points, where you want the P low to be set higher than your lower inflection point and the P high to be set lower than your higher inflection point, to make sure that you don't have any significant over distension at your P high, since that's where you can see from the previous graph, that's where most of the pressure that's applied to the lung most of the time. One of the negatives, I think, of APRV is we don't often have very nice pressure volume loops in a critical care setting when patients are sick. So sometimes determining these high and low inflection points to set our high and low pressures can be very challenging. Some people might have, external ways of looking at these, but, using just the graphics on a ventilator can sometimes be difficult to set them exactly right. So it has been shown again to improve oxygenation, and as I mentioned, decrease the need for sedation. That permission of spontaneous breathing also does improve the hemodynamics with the initiation of every breath and the improved venous return on those negative deflections. However, some disadvantages are that it's very difficult to titrate the vent settings based on the clinical parameters. Again, if we're looking at things like inflection points or esophageal balloons, you might not be able to see those so readily, or they might not be so readily apparent as the patient is either getting better or getting worse. And so unless you're very, very skilled at using APRV and have a lot of experience, perhaps maybe it's your primary mode of ventilation at your institution. These are some things that do take time to understand and to recognize. So using APRV very sparsely is probably not a great approach. Further, there's no evidence that APRV improves outcomes. Again, the PO2 might increase, but the outcomes really don't change. This was one single center randomized controlled trial that looked at APRV versus low tidal volume ventilation. And so there is some data out there that supports a benefit for APRV. Again, these are things, this graph shows percentage of breathing without assistance. So, less mechanical ventilation days might have happened in APRV, less need for sedation. The one thing that I will also caution you with in interpreting some of these other things that show a true benefit for some novel modes of ventilation are what was their approach for low tidal volume ventilation. I would agree with this 6 milliliters per kilogram for a tidal volume set, but a PEEP set by the PEEP FiO2 table from the ARDSNet trial may not be the most optimal PEEP or the most personalized PEEP for that patient. And so could we have optimized them and recognized the same benefits if their PEEP was different? Maybe, maybe not sure. This is another, during the COVID-19 pandemic, a lot of people were switching to APRV as their primary mode of ventilation. Again, as this was a disease of hypoxemic respiratory failure, APRV is often associated with that. So a lot of people went to this approach to ventilation. And what this shows, this comparison of outcomes between the two groups, is that there is no statistically significant improvement in any of these types of things like length of stay, death, need for a tracheostomy, all of those larger things that we think about as ICU outcomes. There was no improvement with APRV. There was no benefit of low tidal volume ventilation. There was no superiority there, but it all goes back to what are you comfortable with at your institution? What do the people managing the ventilator have the greatest expertise in and can recognize either when the patient is getting better and support needs to be weaned, or perhaps not getting better and support needs to be up titrated. There was a meta-analysis done, a 30-year evolution of APRV by a large group of people. Or it was a review article, and really what they said is, in looking through the literature, it's incredibly difficult to do direct comparisons and make any type of determination of, is APRV better for one thing or another. Again, many people, there's different ways to do this. In one ventilator, it's called APRV. In another ventilator, it's called bi-level ventilation, where you're setting a low PEEP and a high PEEP. And so the fact that there's difference in terminology really inhibits the direct comparison. However, no study showed harm or inferiority of APRV over another mode. So there's no benefit, but there's also no harm in using it. So again, goes back to what is your institution and your clinicians most comfortable with. Pressure regulated volume control and volume support are another proprietary mode of ventilation. This can be labeled differently based on the ventilator that you're using. So it's important for you to know what the terminology of your ventilator in particular is. PRVC is pressure regulated volume control, and that is a control mode of ventilation where a rate is set, and volume support is the spontaneous version of PRVC, so akin to pressure support. This is a closed loop feedback mechanism of mechanical ventilation where the target tidal volume is preset. So you're telling the ventilator what you hope your tidal volume to be, and then the ventilator will actually adjust the level of pressure that's needed to deliver that tidal volume. So if your tidal volume is set at 450, the exhale tidal volume becomes 500. On subsequent breaths, the ventilator will down titrate the pressure required or pressure delivered to the patient. Using this mode of ventilation, where it's actually pressure ventilation, so the flow is variable based upon the patient's demand, which is a benefit for asynchrony as well as lower levels of sedation. But there is a target tidal volume, so the ventilator is again monitoring that, and through different algorithms, they adjust the support based on the subsequent 3 breaths or 2 breaths or 5 breaths. It just depends on the ventilator's algorithm. Again, in PRVC, you set a rate. In volume support, you either set a target minute ventilation or tidal volume, but there is no rate set. So this allows the patient to breathe spontaneously with that target tidal volume. The disadvantages, I'll say, of PRVC is that the volume can be variable. So if you have a condition like severe ARDS where you think limiting the tidal volume is most beneficial and you really want a tight control over that tidal volume, PRVC may not be the best mode because there is some variability. It all depends upon the patient's resistance, compliance, and effort. If they take a large effort, then the tidal volume may be large, and then subsequent pressures will decrease. So it really does just depend on the patient's condition. But if that control over tidal volume is desirable, then PRVC may not be the best mode. It can significantly undersupport patients who are in respiratory distress. And I find this to be the major drawback of PRVC. I think, to be honest, it's for a stable patient who needs some invasive respiratory support, it is a fine mode to use. However, when the patient gets into respiratory distress, the ventilator can down titrate support. This is a fairly old article, but it really describes the process and the impact very, very well. These are patients who were using, half of them are using volume support and half are using pressure support. And for 10 patients, they placed a heat moisture exchanger in line. So they increased the amount of dead space that was in the ventilator circuit. And with that, the pressure support level for those patients who were in the volume support mode instead of pressure support actually decreased. And so you might think, well, that's good, right? Like, the patients are getting better. They have lower pressure. When we look at this a little bit closer, the left-hand side are the patients who are on pressure support, the right-hand side of patients who are on volume support. Then it denotes each at their baseline, but then with dead space put in line. What I want to point out is you'll see the airway pressure for the patients who are in pressure support at their baseline and then with dead space ventilation is about the same. You can see the patient certainly more tachypnic, but the airway pressure is about the same. In the volume support patients, the airway pressure drops with addition of the HME or addition of the mechanical dead space. And this might be, again, if you're just looking at this number, that might seem like a good thing. What I want to point your attention to is the line right above it. The esophageal pressure of those patients on pressure support stayed the same. But in the volume support patients, when the airway pressure dropped, the esophageal pressure greatly increased, meaning this patient has significantly higher work of breathing. You can see the diaphragmatic pressure as well also increased. And the ventilator is actually supporting the patient less at a time when they need it the most. So It's really for patients who have either changing dead space fraction or who have a significant metabolic acidosis is another patient population where PRVC may not be the best mode because the ventilator interprets these large tidal volumes as the patient lung compliance or lung resistance getting better and will down titrate the support. Proportional assist ventilation is proprietary to the Puritan-Bennett ventilator. However, there are other modes of ventilation and other ventilators that are coming out that kind of mimic the theory behind. And what this looks at is it adjusts the ventilator support based on the flow and volume generated by the patient, but with a look at patient effort. So it looks at the work of breathing and calculates that in joules per liter. You can see that at the bottom. And what you do is the ventilator will periodically do an inspiratory pause where it then can measure compliance and resistance of the patient and make determination about how much support to give to the patient. You set a specific level that you want supported by the patient, and as long as the patient stays within, this green target area, the patient will be supported. If the patient work of breathing tends to increase a little bit, so will the support for the ventilator. Some of these are set a percentage of minute ventilation. Again, it depends on what ventilator you have and what the algorithms are that are built in. So it's important to understand those. This can be something that, has been shown to aid in weaning off of mechanical ventilation. However, if you, again, don't use it, but rarely, you might miss some signs that either the patient's getting better or getting worse. So there's no harm in using it, but you do have to kind of master the skill of using this because it's a different way of looking at the work of breathing of the patient and a different measurement of it continuously displayed here. Again, some of these recent studies have shown that weaning success with PAV, excuse me, overpressure support is higher. There's lower intubation rates, less ICU stay, as well as duration of mechanical ventilation. So again, there are benefits, but you do have to become really skilled at using it. I threw high frequency oscillatory ventilation in here because it's always something interesting to talk about. We don't, at our institution, typically use it in adult patients, although I know some institutions do. So the mechanism of high frequency oscillatory ventilation is that the mean airway pressure is set. This dotted line is the pressure that oscillates around the mean airway pressure. The mean airway pressure is the horizontal dotted line. You can see overlaid is the solid line of the pressure control ventilation tracing out each breath. So the reason that high frequency works is because there's more frequent oscillations around this mean airway pressure clearing the CO2, but there's typically, I'll say, lower delta pressure from PIP to PEEP with high frequency ventilation. So some people will refer this as gentle ventilation. It is gentle, certainly if you use pressures that are gentle. If if the patient's not tolerating it, not improving, you start increasing all of the pressures, it no longer becomes gentle, and you then have more shear stress on the lung because the cycles per second, or the hertz, is much higher than what you would see on conventional ventilation. One thing to note is that exhalation is active, whereas in conventional ventilation, exhalation is passive. So there's a piston within the ventilator that actually moves back and forth, and it will actually pull gas out of the lung on the backwards displacement, which creates exhalation. Again, there's great neonatal applications that have been shown to work. Some places use it as their first intention strategy for mechanical ventilation. Others use it more as a rescue therapy for neonates. In the adult application, there is some data that looked at whether or not it should be used as a rescue therapy for ARDS. However, oh, sorry, I don't have it on here, but I think it's well known that the outcomes were significantly worse. I thought I had a slide in here with it, but significantly worse using high frequency ventilation in adult patients. So that's why it's not so common. There are drawbacks. In specific, it requires an entire new ventilator that you can see doesn't even look very modern. The tubing is very rigid and heavy. It's different than conventional mechanical ventilation tubing, where this can certainly add to displacement of the endotracheal tube. There's difficulty moving the patient, which we all know is imperative to ICU care. The clinical assessment is gone. One thing that we look at with conventional ventilation is using things like what is the respiratory rate, what is the tidal volume, to help guide our assessment of the patient improving or not. And with high frequency ventilation, both of those things are gone. What is assessed is what's called chest wiggle, which is a very subjective assessment. My chest wiggle might, or assessment of chest wiggle might be different than yours. And we might miss it if, it might mean something different if we're assessing it differently. Further, sedation, high level of sedation, and perhaps muscle relaxants are often necessary for the use of this device, as well as impaired cardiac function due to the higher main airway pressure that's constantly in the thorax. So there's, I think, more drawbacks to high frequency ventilation than there are benefit. This is what I was looking for. So this Cochrane review showed us that there is no benefit of high frequency over conventional ventilation for all of these randomized controlled trials. Adaptive support ventilation is, again, proprietary to specific ventilators. There are different ventilators might have different modes that, again, act the same way based on the same principles, but are called something different. The basis of ASV is the Otis equation that looks at the compliance, the resistance, as well as the minute ventilation. And there's a series of test breaths that the ventilator delivers with a pressure control of 15 centimeters of water. All of the time constants, the plateau pressure, the auto PEEP, those are all estimated during these series of test breaths. And then the ventilator sets what it thinks the patient desires. So the whole goal is to mimic how the patient's desire to breathe, but again, with enough support that the patient does not have increased work of breathing. There's been a lot of information about when to use ASV. Post-cardiac surgery has been shown to decrease the time on mechanical ventilation and less ventilator manipulation and alarms, which I think is something really important for us to consider, with different stresses or responsibilities placed on ICU level of clinicians. Is it better to have a ventilator that has this closed loop feedback where it's really constantly measuring these parameters of the patient lung, chest wall, where the ventilator will titrate to the patient without having a clinician to be at the bedside to manipulate that directly? There's also some benefit for long-term vent weaning, and again, spending less time on the ventilator. And then, it has been shown to be sufficient for patients across all types of lung disease, normal lung mechanics, restrictive and obstructive. So there is no real subset of patients where ASV is not appropriate for. Again, I think it comes back to understanding the mechanism, the physiology, and then how the ventilator adjusts to the patient. NAVA is another really interesting mode of ventilation that, I think has a great role and great benefit. And it mostly revolves around the control of breathing. You all know that this is the normal control of breathing, that there's a signal in the brainstem that then travels down the phrenic nerve, activates the diaphragmatic muscle to contract. Pleural pressure then drops, which expands the lungs and drops the pressure or flow at the airway. And then the ventilator recognizes that and gives, support, whether it's pressure or volume, as airflow into the lungs. This is all fairly quick, but there is some time delay in this. And so NAVA actually uses a specialized nasogastric tube um, that is inserted to the patient and has electrodes that cross the diaphragm. So these electrodes can pick up on the diaphragmatic signal. Let me go back a slide. So instead of the breath triggering here, NAVA allows us to trigger the breath here when the diaphragm actually contracts. So this can aid in patient ventilator synchrony. If the ventilator, has a very slow response to the patient can exhibit some increased worker breathing into synchrony. Also, if the patient has significant autopeep or airflow obstruction, even if the diaphragm contracts, if there's no drop in pressure at the airway, the ventilator will not recognize that. And so using NAVA can actually improve the synchrony and triggering of patients who have significant obstructive disease. The other thing that NAVA does is it actually measures the strength of the diaphragmatic contraction, and that's what's called the EDI. And it can adjust support based on that strength of contraction. And of course, there's a range that's set on the ventilator, but as the contraction actually increases in strength, the ventilator interprets that as the patient's trying harder to breathe, so will support the patient more. But then when that diaphragmatic contraction perhaps settles back down, then the support from the ventilator then reduces. So it sounds really great. A lot of people say, when can I get it? However, with many other things, it can be fraught with technical limitations. That nasogastric tube that has the electrodes can be very expensive. It does have to be a specialized one that has the electrodes that cross the diaphragm. And then it has to have the exact adapter on the external end to connect to the ventilator. In order for it to work, the electrodes have to be in the right placement across the diaphragm. If there's perhaps some abdominal pathology that, has developed over the last so many hours, and the diaphragm perhaps is upward displaced a little bit, maybe those electrodes are not crossing the diaphragm as well as we would like. You can see that signal and adjust it, but again, it takes someone to be looking at it and to be assessing for that right signal. Of course, if there's displacement of the NG tube itself, those no longer can sense the diaphragmatic contraction. And in those cases, it essentially, the ventilator will act like either pressure control or volume control, however you have it set. And NAVA is only available on servo ventilators. So if this is something that you think is the right thing for your patient population, you may, if you don't already have servo ventilators, you might have to buy a whole new fleet of ventilators, which is not a small investment. There is data to support its use, however, and it's something that you just have to weigh as an institutional decision, a clinical decision, where patients who had hypercapnic respiratory failure, they were either placed on controlled ventilation with lung protective ventilation, or placed on NAVA. And sorry, I went the wrong way. It certainly showed that there's more ventilator free days when using NAVA, things like total duration of mechanical ventilation and extubation failure were also improved. So some certain outcome measures, but again, this is an institutional decision that, you have to kind of weigh what the cost to benefit is. One thing that we focus on a lot is asynchrony in mechanical ventilation. And because NAVA does look at the diaphragmatic both activation as well as strength of contraction, it can actually reduce the level of asynchrony and ineffective efforts, which is a leading cause of increased work of breathing and dyspnea in patients who are mechanically ventilated. This looked at using NAVA in children. And I know we're primarily adult clinicians, but I thought it was just really interesting where if you look at the pressure control and volume control group versus the NAVA group, their tidal volume was pretty much the same. Their driving pressure was much lower in the NAVA group, but also their pH was more often in the correct range of 735 to 742 than in the pressure control group and the volume control group. So the ventilator actually really was able to respond to the patient and support them in the best fashion. So, it's something that I certainly would not, I would support using NAVA for sure. Again, this is in children, but a systematic review to just highlight that it is safe and feasible. It can be superior over conventional ventilation to improve patient-ventilator interaction, the synchrony part of things. But there needs to be bedside monitoring. It can be useful in things like diaphragmatic function, as well as I mentioned, patients that have severe obstructive disease that may not be able to trigger the ventilator. You can see that more clearly when using NAVA. So in conclusion, what I'll encourage you to take home is that we typically want to, in our art of medicine, mimic how the body typically works. So the example I use often is when a patient has renal failure, we don't just put them on dialysis. We often give them some sort of medication that will help their kidneys to function more appropriately, but kind of aid in that functioning. So shouldn't we do the same thing with mechanical ventilation? A lot of these modes are proprietary to devices or have proprietary components where there's a financial investment that you have to make, and really there's no overwhelming data that says any one of these novel modes is better than another when we talk about patient outcomes. So I think for clinicians who don't use these modes frequently, and this is respiratory therapists, nurses, physicians, we may miss some of the clear signs that when we're using more physiologic breathing, mimicking physiologic breathing with mechanical ventilation, we would perhaps see those a bit more clearly. So these novel modes can certainly change what your blood gas looks like, but again, we don't have really that outcome data that is pointing us in one way or another to say this is absolutely the mode that you should be using. Thank you.